Welcome back to the Band-Aid Man OC, your source for all things sports medicine, EMR, and of course, EMT. Today, we're going to be jumping into Chapter 4 of the Emergency Care Textbook. And of course, this is the 13th edition. So if you're using a later or earlier edition, please note that it's not going to be exactly the same as what you're looking. Now, in Chapter 4, we're going to be talking about the medical, legal, and ethical issues that are a part of our day-to-day work as EMTs. Now, this chapter is very important because although we are doing a dive into the medical and legal aspects of what we do, it is just barely scratching the surface. And if you know anything about the legal system, you don't want to be the one that doesn't understand the legal ramifications of what we do. So while we're going through this, please understand that when we talk about the aspects of the AMA, also known as the Against Medical Advice format, there is much more in-depth information that you must be proficient with before you go out into the field as an EMT. The DNR POLST, which is the Do Not Resuscitate and Physician's Orders for Life-Sustaining Treatment, is going to be much more in-depth. And as I've said before, and will continue saying through all of these videos, the training that you receive when you get to your agency, to your company, to wherever your place of work is, will dictate what aspects of medicine, legal, and ethical parts you'll actually go into. Now, the ethics is pretty much the same. We always want to make sure that we don't induce any kind of harm to our patient. We want to make sure that we are operating as an advocate for them so that we can say we are looking out for the best interest of our patient. Really, if we're doing things that are hurting our patient now, there's very little chance for us to say that it will help them in the long term. So just something for you to all think about. But remember, wherever you work will have very specific legal ramifications of the job, and it is your responsibility as the EMT to understand those bits and pieces of information so that you can be as well prepared to do the job as safely and as legally responsibly as possible. Now, today we're going to talk about three specific umbrella terms, or three specific umbrella parts of the chapter. First and foremost, we're going to go over your scope of practice. Then we're going to move on into patient consent and refusal, which is super, super important. So be sure to take notes and pay attention there. And then finally, we're going to finish off with a bevy of different legal issues that will come up in your line of work. But without much further ado, let's do it. Now, scope of practice. As an EMT, your scope of practice will be determined where you work. That is really the end-all determination. As an EMT student, you will begin to learn all of the scope of practice that's set forth by the National Registry of EMTs, or Emergency Medical Technicians. That is the framework for the bare bones basic version of the education you need to receive. Further on down the line, depending on where you work, you will have to follow the scope of practice as set forth by your state. Then, even more insulated and insular, your local EMS agency, or LEMSA. And then finally, you may even have a more aggressive scope of practice based on the city or municipality that you work for. And typically in the past, we have called these an expanded scope of practice, although at least where I teach, that term seems to have been poo-pooed. People get real concerned about it, so they're really not calling it an expanded scope anymore. Now they refer to it as a local accreditation, or they've simply gone with the model of our state, which is California, is good enough for our scope of practice within the county. So it can be a little bit difficult to remember. So at the end of the day, remember that your scope of practice will be defined not only by the state and locality that you work in, but also it may even possibly be changed by the agency or municipality that you actually work for. But at the end of the day, the scope of practice is this. It is the regulation and ethical considerations that define your scope, that define the limits of what you can and cannot do as an EMT. And again, really where you are will change that fairly drastically. What an EMT can do in one county here may be only extended to the borders of that county. And then when they leave that county and go north, south, east, or west, and really mostly it's all going north, south, or east out here because we're right on the water. So if you go west, you're basically in international waters. What we're really trying to say is that your job is going to change based on geographic location. Okay? So why do we bring this up? Why do we talk about the scope of practice? Well, your scope of practice is what you can and cannot do. The standard of care, on the other hand, is how you do the job. Again, the scope of practice, what you can and can't do. The standard of care is how you do it. So the standard of care is broken down into how you would be expected to train at a specific level when compared to another EMT. The scope of practice will tell us really what tools we're allowed to use, and the standard of care will tell us how we can use those tools. So this helps us reduce liability, not just for ourselves, but also for our coworkers, for our agency, municipality, city, state, so on and so forth. And that standard of care should always have the ethical implication of you operating as a patient advocate. Now, in my class, I tell my students, you need to treat your patient as if they are one of your loved ones. They are your parent, your brother or sister, your guardian, your grandmother, grandfather, because in that instance, it is likely that their loved ones will not be present. And it's very likely that during the transport, their loved ones will not be present because most of the time we don't have family members riding in the back unless they're little kids. When you operate with this concept of being a patient advocate and really putting yourself in the position of being that person's loved one, you will start to take the job a bit in a different light. You will start to think, gosh, would I do this or that to my grandparent or to my loved one? And the answer almost always is no. So I would always encourage you to operate in a way that would help you feel like you are extending the best wishes of the loved ones of your patient. Now, when we get into patient care, consent and refusal basically is the onus under which we need to prove we were allowed to do our job. If we don't get consent, we can be charged with a whole litany of different crimes, and we're going to go into those in a little bit, but really, consent is just as important as knowing how to do the job. Consent really does fall under our scope of practice and our standard of care. Let's dive in. With consent, we have two different specific types. The type that we see most often is known as expressed consent. Now, expressed consent is when your patient acknowledges that you are there as a medical professional, you are there to help them, and that they are consenting to, at the very least, your initial assessment and anything that would go in to guarantee that we know what we're seeing is correct, such as vital signs or hooking them up to a diagnostic machine like a blood pressure, an automatic blood pressure cuff, a cardiac monitor if we're working on an ALS unit as a one-on-one or ALS with a BLS EMT, so on and so forth. So basically what we're trying to say is we want to check you out and we want to assess the severity of what's going on, but we also need to do these things. So with express consent, we have a condition. So expressed consent, that is the type of consent that we're talking about. All express consent must be informed. That's the condition. The condition of informed consent basically states that our patient understands what we're doing. When it comes to basic diagnostics like a blood pressure, a pulse, skin turgor, or checking the skin for its ability to go back into place, which would be a good indicator of relative dehydration, a temperature check, anything that we're going to do where we have to actually put our hands on our patient does require some type of informed consent. Now, I don't need to sit there and explain to my patient what a blood pressure is unless they ask, but really, it's as far as this. Sir, my name is so and such. I'm an EMT and I would like to take your blood pressure. That's pretty simple, but that only covers blood pressure. So what's a more blanket term? Sir, while I'm doing your assessment, I would like to get some vital signs, pulse, respirations, blood pressure, skin signs, things like that. Is that all right? Cool. Now, the ongoing conversation between your patient and you is known as patient rapport. We also refer to it as bedside manner. These are all very fancy terms that basically mean you know how to talk to another human being. If you don't possess that ability, if you are afraid to talk to your patient, establishing a rapport is going to be very difficult. So while we are obtaining consent, express consent that is, we also need to make sure that the person who is giving that consent is legally able to. And the legality of that comes from a number of different things that we'll talk about in a bit. On the other hand, implied consent is much different than expressed. Implied consent is the concept that the normal average person would want the treatment that we are about to render. This is utilized for a lot of different patients, but it's a blanket statement and a blanket type of consent that we obtain on patients that are physically unable to express consent to us. How does that work? It's pretty simple. Hi, what's going on today? I'm so and such. I'm an EMT. No response. Can you hear me? No. Once you start trying to assess your patient and we find that they are unconscious, unresponsive, less than responsive, or confused to some degree, or do not meet the legal requirements for an adult to express consent, meaning that they're under the age of 18, they are pretty drastically under the influence of drugs or alcohol, or are unable to show that they have regular mentation, which is that their brain is firing on all cylinders and they can answer 4 basic questions, we're going to treat them as if they were unable to give that consent and that they would want the type of treatment that we're about to perform. So implied consent is, again, that presumption that this person would like treatment that we would render to anybody else. When we are dealing with consent, especially with adults, we need to make sure that the adult is competent, that they are able to answer all of our questions. So before we go any further, I do want to get into establishing mentation levels in your adult patients. Now, in my class, I usually scar all of my students with a terrible little song and dance, and I call it the PPTE dance. It's really, really bad, and I won't do it here because in addition to being really terrible, it's also definitely copyright infringement because I'm basically just riffing off of a song that someone else wrote. But basically, you want to hit those 4 questions, PPTE. That stands for person, place, time, and event. We can break that down even further. The 4 questions I need to find out if they can answer are, who are you? So what's your name? Where are you? As in, where are we physically right now? What time is it? And this can be variable. The time of day, the relative time of day. Is it morning, noon, or night? The appropriate meal time. Is it time for breakfast, lunch, or dinner? And these things may be important depending on where you find your patient. Because as we all know, the more that we spend time indoors, the more difficult it is for us to gauge the time it is outside. This would be especially important on patients that are in skilled nursing facilities. Most patients, our elderly patients in skilled nursing facilities, are able to tell what day of the week it is based on what check they're writing or based on certain activities. And if they don't have access to those things, we need to change our questioning so that we don't incidentally infer that they are not alert and oriented. Now back to our questions. We've already got person, place, time. Finally, we need event. An event stands for what brought us here. It's not normal for us to go and have conversations with the public. Not to say that we're afraid of the public, but we're not normally showing up to people's houses and saying, hey, just your local friendly EMTs. We heard you were making waffles. What's up? You don't have a chair for us? Don't worry. We'll take it on the road. We don't show up just to say, hey, what's up? We show up when people call 911. So if we're showing up and they can't tell us why, there's a serious, significant problem. And we need to address it right away. So again, as review, for adults to show that they are competent, they need to answer these 4 questions. Person, who are you? Place, where are you? Time, what time is it? And event, what brought us here to have this conversation with you? As long as your patient can answer all those things, we consider them alert and oriented. And again, this is a local thing. We call that alert and oriented times 4, or A and O times 4. If your patient's alert and oriented, congratulations, we're good to go. If your patient's not alert and oriented and they're an adult, we're going to go ahead and we're going to treat them under implied consent. And this is, of course, if this is a new onset of altered mental status. If your patient is always confused because they've got dementia, Alzheimer's, something of that nature, we need to confirm with caregivers that the level of confusion that they're currently showing is much different than what it normally is. We'll talk about that more later. When we get into groups that are not actually able to give consent, we have a whole nother legal hurdle to jump over. And this deals with children and mentally incompetent adults that are not just confused. A child is considered anybody under the age of 18, but there are 3 specific times when we can disregard their age and treat them as if they are an adult. Situation number 1, a legally emancipated child. Now, emancipation differs from state to state, and it typically is something that's only recognized in their own locality. But an emancipated minor is someone that has been legally declared by a court of law as no longer needing the guidance and supervision of a parent. They are financially independent. They are physically independent. They do not rely on their parents to do things. We're seeing a lot of this now with the sudden surge of content creation, especially here on YouTube, but also in other areas. So we're seeing a lot of other individuals, minors, that are able to get themselves legally declared as emancipated because they have a full-time job, because they do not depend on the help and support from their parents. 2 other situations. Situation number 1, we have our child that is a parent themselves. Now, this normally only really applies to female patients, and by female patients I mean they have just recently given birth or they are currently pregnant. But under the legal ramifications, it could also be extended to the father as long as the father was there. This gives our minor patient the ability to take care of not only their own healthcare needs, but also the healthcare needs of their unborn or newly born child. That's why that exists. The third and final reason that a minor may be considered exempt from the consent laws that we would normally treat them under is if they are actively enlisted in the military. And this is in the United States military. So they can't say, oh yeah, I joined the French Foreign Legion, or I joined some other country's military. That's fine. But that's not how it works here. So typically we find this of individuals that are about 17. They've signed their enlistment paperwork, and they are going to be starting their journey as an enlisted service member before they actually turn 18. The way to prove this is going to be through their military ID and then background checked with their state-issued ID. These are the 3 people that are under the age of 18 that can actually refuse our care as long as they are alert and oriented times 4, and they're not under the influence of drugs or alcohol. Again, that's going to be emancipated minors, a minor that is a parent of a child of their own, and typically, again, that's reserved for females. And then finally, we have our children that are actively enlisted in the military. So, we have other exemptions to this, but it really has a lot to do with the way that your locality treats individuals that are adults that are under some type of care by another adult. And we're going to talk about that in a minute. This is an example of a proof of emancipation document, and this is very specifically, it's for a community college. So this would be the kind of thing that you would see that a child would carry if they were on a college campus. This is something that you'll see on a rare occasion out in the field, but in my own experience, I haven't actually had any of these patients, so it's difficult for me to say how often they actually come up. Anytime that I've had a minor patient say that they were emancipated, they've really failed on showing any kind of documentation, and normally that's when we get law enforcement involved so that they can verify. And every single time there's been no verification that we've been able to make, so we treated them as if they were a minor. When it comes to mentally incompetent adults, however, we may have a patient that is over the age of 18 that is not able to make their own decisions for a number of different reasons. Reason number one, they do not possess the mental capacity to make those decisions. This could be applied to individuals that are developmentally delayed. This can also be applied to patients that have some type of a medical issue that is causing them to not understand the ramifications of their decision, whether that be a TBI, traumatic brain injury, some type of early onset dementia or Alzheimer's, or perhaps the fact that the patient is deteriorating for another reason, such as cancer. Then we have other patients that, due to a number of different reasons or a number of different conditions, may have been found incompetent by a court of law alongside their physicians and have been assigned a conservator. Now, I don't want to name drop any famous people out there because I don't want to make them feel bad, and I definitely don't want to get eaten up by the YouTube community. So this is what I will say. There are several celebrities that are constantly in the news cycle that are actually under conservatorship right now. These individuals are having their legal decisions made by somebody that's been appointed by the court system, typically a family member, parent, something of that nature. And the reason that that's occurred is because the individual has expressed many times that they are not in a mentally secure space where they can make worthwhile decisions, or I'm sorry, not worthwhile, but safe decisions for their own safety, whether that be physical safety, emotional well-being, financial well-being, so on and so forth. The other kind of situation in which we would find consent to be something that would be more than just talking to the patient is if the patient has enacted a healthcare power of attorney. A healthcare power of attorney can make a lot of decisions, and specifically will make decisions based on the health and well-being of the patient. This is typically found in older patients, especially ones that have terminal or end-of-life diseases, and they simply want to be able to cede the control of their care to somebody that is not going to mess things up. This is usually ceded to a loved one, whether that be a spouse, a close family member, a child, and this is typically done because the person does not want to lose that ability. They lose consciousness, they lose responsiveness, they go into cardiac or respiratory arrest, and they don't want to lose the ability to have their wishes maintained. And the healthcare power of attorney, or HPOA, is somebody that is duly appointed by a legal authority and has witnessed signatory pages by the patient's physician, a legal representative, and a witness, as well as the patient, as long as they have the capacity in which to do that. These are individuals that can actually change the course of care depending on what all is going on. When we get into the aspects of involuntary transport, it could be for a number of reasons. Reason number one, the patient simply does not have the ability to refuse our transport. So they're under the age of 18, they don't meet those other exemptions. Our patient is not alert and oriented. Of course, the patient that is unconscious, unresponsive, or in cardiac arrest, they can't really refuse. But then we get into the individuals that are perhaps heavily under the influence of drugs or alcohol. They are currently being assessed and held against their will because of some type of a psychiatric or behavioral disorder, or based on the fact that they are no longer considered a free, independent individual. And these would be individuals that are under arrest. They've been legally detained or legally arrested. Now, Involuntary transport for us usually falls under the medically, I like to call it the medically arrested. Now, I know that that seems a little weird, and I know that there's a lot of folks out there that would like to just, light up their torches and get their pitchforks and say, "This is America, you can't take us." Rawr! Yeah. I get it. Everybody's a free person, and everybody is entitled to their own freedom. I get that. I appreciate that. However, if you say certain things, if you act a certain way, and we have a mental health professional that can come out and prove those things, we're going to have to put you in a place where we can evaluate you. Now, there are three specific conditions. There are three specific implications in which we can take away your rights based on a medical issue. These are known as being a danger to yourself. So you've stated that you are going to kill yourself or commit great or grievous bodily harm to yourself. We refer to that as DTS, danger to self. Then we have DTO, danger to others, where you have expressed that you are going to injure or kill other people, and you have expressed that in a way that not only shows intent but also shows the means. A little bit more aggressive way of referring to this would be homicidal ideation. Whew, sounds super creepy. And then finally, we have our patients that are GD, gravely disabled. An individual that's gravely disabled has deteriorated to the point where they are no longer taking care of themselves. And if we leave them alone, they will simply die because they are not taking care of themselves. This is one of the least common types of hold, and it can be legally a bit murky. So because we rarely use these, it's not something that I can speak to on a very broad spectrum scale. So I will speak to it under a specific scale. These would be individuals that are engaged in behaviors that are simply so harmful that we can already see the health effects. These would be individuals that are not taking care of wounds to their body. They are no longer eating or drinking, and this is not a voluntary choice. They simply have decided that they are not going to do that anymore, or somebody that has left themselves in such poor conditions at home that the state, and of course I'm speaking specifically to the state of California where I work and teach, the state of California has said, we simply cannot leave you at home because you will die there. So when you are dealing with involuntary transportation, a couple of things are very important to remember. Number one, document everything. Everything must be documented. Number two, you must have legal documentation to prove that this transport is legal. This documentation comes from our fine folks with what we refer to here as the PET or CAT teams. PET stands for Psychiatric Evaluation Team. CAT stands for County Assessment Team. And typically these are teams that are comprised of law enforcement, mental health, and physicians, or other type of clinical practitioners, such as nurse practitioners or physician's assistants. This is an example of a California 5150 form. The 5150 is part of the California Health and Welfare Code, and because we're going to go into an entire chapter on it, I don't want to spend too much time here, but this form is what you will transport, the original, I might add, with your patient so that they can be assessed at a psychiatric assessment facility. If your patient does not meet those requirements, if they are not being medically arrested, and I'm putting up air quotes right now, but they are not being involuntarily transported, they are an adult, or they meet the exemptions for children, and they are alert and oriented ×4, they can refuse your care. We can't run around and say, I know better than you. I went to school for 6 whole months. Yeah, baloney. That's not how that works. It's not even how it works if you can say, I know better than you. I went to school for 15 years. Fantastic. Thank you, doctor. But we, again, have a very strong admiration and demand for personal freedoms, even if that personal freedom can hurt and or kill you. So if we have a patient that's refusing care, they need to meet these 4 bullet points here. Number 1, Your patient must be able to legally consent. So they must be over the age of 18 or meet the exemptions, and they have to be able to answer those 4 questions. That is our next bullet point. Your patient must be awake and oriented. They need to be able to tell you who they are, where they are, what time it is, and why we are there. Number 3, the patient must be fully informed. They need to not only be informed of the fact that they are having a medical emergency, but that by refusing your care, that medical emergency could potentially become much worse and turn into a fatal or life-altering event. And then finally, number 4, they must be asked to sign a release form. They're not required to sign it, but we want to strongly encourage them to do that. This leads us all back to liability. And even though we have done all of these things, we may still be found liable. Now, a lot of my students like to say, well, Johnson, how does that possibly work? How can we be held liable if we meet all of these conditions, if we hit all these bullet points? And my answer every time is that anybody can sue anybody for anything. I'm going to repeat that. Anybody can sue anybody for anything. The reason, well, we live in a country and in a time that is fairly litigious, which is a big fancy word for sue happy. I can say to one of my acquaintances, you know what? Sure don't like your hat, and I'm going to sue you for it. Now, there's a very small chance that that is going to go anywhere beyond my initial brief to the courts. It will most likely be dismissed as being frivolous, and if I'm dismissed too often for frivolous lawsuits, I may actually be barred from continuing to send in these petitions or these requests to sue an individual or to sue a group or to sue anybody. So it is a system that, while it does technically give anyone the ability to sue anyone, it does have its own internal protections. So understand this. You may do all the right things and check all the right boxes, but you may still be sued. Thankfully, if you've done all of those things, your case would likely be fairly strong and difficult to prove that you had done anything incorrectly. When we're dealing with a patient that's refusing care, one thing that's important to remember is that we are actively telling our patient, hey, I really think you need to go to the hospital. Now, we get into some murky territory here, so I want to explain myself. You will find patients that are calling to go to the hospital by ambulance that you can look at and say, there is no way that any medical provider would ever feel like this is a reasonable transport. I've been called to places because somebody had a nightmare. A nightmare is not an emergency medical situation. If I took the patient to the hospital and said, yep, the chief complaint, nightmares, they would have some serious questions like, how did you even decide to transport this patient? I wouldn't be able to submit paperwork that said that the patient's chief complaint was a nightmare. It's laughable even saying it. But at the same time, we also have to remember that, what our patients report, while it may be something that's important, we don't have the ability to necessarily state that that is not a viable medical issue. All right? So, when your patient refuses care, try to persuade them to go with you to the hospital. Take some time to talk to your patient. Try to understand better why they are refusing care. The most common reason? I can't afford it. This is when you need to start to get into the lexicon of, your ability to pay should not affect your ability to get decent health care. We can work with you. We can set you up with a payment plan. We can do all sorts of things, but do be very cautious. Don't overstate what you can and can't do. The best blanket statement I've ever heard is your life worth the amount that, the hospital or the ambulance will charge you? And, to some people, they'll say, yes, absolutely. I cannot afford that. That will drastically affect my life. And depending on where you work, that may be a very true statement. Ambulance trips are not cheap. So work with the patient and try to understand what's going on. But at the end of the day, if they do not want to go, we must inform them of the consequences of refusal. And the consequences will always be the same. Your refusal to go to the hospital with us could lead to further complications. including but not limited to death. You may die. So, what does a AMA actually look like? Well, the AMA itself is us saying, I have given medical advice. My patient has refused my medical advice. And as a result, I'm asking them to sign a piece of paper that says that they are releasing us from liability. We've also got a lot of tools in our bag. If you have the ability or your system requires that you call into medical direction, make sure that that happens. Don't leave the scene until you call for medical direction. Let them know that that is what's going on. Give them alternative options. Is there a family member that they can ride in with? Is there a way that we could get them a ride share, Uber, Lyft, whatever the case may be? Is there any alternative that would get them to the hospital tonight, today, right now? Because if we can find that alternative, we can still have them sign the AMA stating that they're not going to take the ambulance. However, we are looking out for our patient's best interest. We are operating, look at that, as a patient advocate. Now, that's not going to be appropriate in all situations. If your patient is bleeding out both their eyeballs, you probably shouldn't shove them in an Uber, because the Uber driver is probably going to be a little upset, saying, why are they bleeding out of both of their eyeballs? Why aren't they going with you? Tell you what, we'll switch. You drive my Prius, I'll drive the ambulance. It doesn't work like that. We need to be cognizant of what we're sending. If it really is a medical emergency and it wouldn't be appropriate to put them in a car, in a taxi, we have to let them know, look, we're not going to sign off on that. You're just stating that you're not going with us. However you decide to get to the hospital is up to you, but we're not going to facilitate. If you feel that what is going on has some type of a legal edge to it, and I don't mean the liability aspect, I mean the patient could potentially be breaking the law, they've been the victim of a crime, they are under the influence of drugs or alcohol, call in law enforcement. That is going to be your trump card. That's going to be the thing that you say, all right, I've tried everything else, here it comes, here's the kitchen sink, and we heft that into the mix. If we can't get our patient to go ahead and ride with us, we'll go ahead and we'll have them fill out an AMA, or against medical advice. Now, this is just a sample, and it may be a bit difficult to actually view, but basically what we're asking them to do is say, hey, I've been fully evaluated by the person that is having me sign this document. That evaluation has shown that I have a medical reason to go to the hospital, whether that be a traumatic injury, a medical complaint, whatever the case may be. Due to my insistence that I not go, I am stating that I have been informed of all of these things, and I've also been informed that my refusal can result in further illness, injury, including death, and that I am okay with that. I've also been informed that if anything changes, I can always call back and be transported again, which really leads us down the line of what our responsibility is. As an EMT, as a paramedic, as a pre-hospital provider, our job is to make sure that our patients know, look, if something changes in the next 5 minutes, 5 hours, or 5 days, you can always call us back. This AMA is not a binding document in the sense that you're saying, all right, well, you used up your one call to 911 this week, better try again next week. It doesn't work like that. This is basically just limiting our liability so they can't come back and say, I didn't know that a heart attack was so bad. And now that I'm on the donor list for some new pig's hearts, I'm kind of upset. So I'm going to sue you. So it's important that we get that kind of documentation. So think about this for a second. What are the risks of beginning treatment or transport without getting consent from your patient? Let me tell you, if you don't get consent, if you don't take the time to do that, and you start treating your patient, you can be accused and found guilty of battery. If you start moving your patient without their consent, you can be accused and found guilty of kidnapping. And I don't know about any of you watching this video. Hey, everybody's got their own thing, different strokes for different folks. I don't want to be accused of any crime where I'm going to do anything in terms of illegal activity. I don't want to be accused of battery, assault and battery, battery and assault, kidnapping, any of those things, because they're all bad news bears, and they're all going to end up with me losing my job. Then, what if your patient refuses to sign your AMA form? Well, that one's pretty easy too. If your patient refuses your AMA, we can go ahead and have witnesses sign the refusal in their place. A witness may be another family member, it may be a significant other, it may even be just some other crew member that is not actively involved in patient care. We want to try to find an independent third party, and a lot of my students ask, so can I just get a random bystander to sign it? No, because that puts us in a situation where we are violating HIPAA laws, so it needs to be someone there. If we don't have anybody there, maybe a good time to see if law enforcement's available so that we can get a signature on the refusal from them as well. And of course, remember, if they change their mind, they can always call us back. That's super important. If we have anybody that is with the patient, we want to try to educate them. Hey, you know what? Stay with this person. Make sure that nothing changes. We are concerned about their medical well-being, and if anything changes, call us back, or you can load them up into your vehicle and take them to the hospital. These are the closest hospitals. This is what we recommend you take them to. And then make sure that you have thorough documentation. As I've told my students just this last week, we're at a point, an inflection point in EMS where a lot of our job is being changed, much like the job of law enforcement and the job of fire and rescue personnel. There's a decent chance that we're going to start wearing body cams in the next 3 to 5 years. And the reason that we're going to start wearing body cams is because we're constantly being pulled into court under accusations of not doing our job. And most of the time, those accusations are completely unfounded. That's not always the case. There are bad apples. But at the same time, we have a very significant issue with HIPAA, with the privacy laws that we've talked about and will continue to talk about. So if you don't think that your job is going to change while you are in the process of learning how to be an EMT, working in that first 2-year cycle, I'm going to tell you right now, it may be sooner than you think that everything starts to change. Moving forward into another legal issue, do not resuscitate orders and physician orders for life-sustaining treatment, also known as a DNR and a PULST. These are legal documents that allow the patient to express their wishes, especially in an end-of-life situation, without being able to say anything, without being conscious or responsive or clinically alive. A DNR is usually part of what we call an advance directive. A DNR stands for do not resuscitate. In the state of California, a DNR needs to be also associated with a physician orders for life-sustaining treatment, because the DNR order is basically the legal documentation that says we're not going to take care of them, but the PULST, or physician order for life-sustaining treatment, is what's going to tell us what we can and can't do. This is a DNR order. If you read it, it's pretty simple. The patient, the doctor, the witness, they are all signing for consent. It doesn't tell us what our patients want. And for those of you that are new to CPR, you already know that CPR is more than just providing chest compressions and artificial ventilations. This is the California State EMS version of the PULST. And you can see it's actually broken down into 4 specific segments. Sections A, B, and C all speak specifically to different types of treatment. As EMTs, we're really only going to be doing stuff within letter A, cardiopulmonary resuscitation. Do they want chest compressions or do they not? Do they want artificial ventilations or do they not? B is where we're going to get into ALS or paramedicine. This is where we start into getting into medications, IVs, advanced airways. And then C, this is where we get into palliative, definitive, and clinical or clinician-based care in the hospital. And this is where we get into artificially administered nutrition or tube feeding. Each segment is important to note because a patient may want chest compressions, but they don't want artificial ventilations. They want an IV and medications, but they don't want intubation. They want some IV fluids given, but they don't want full parenteral nutrition or TPN. When we are dealing with a PULST, when we're dealing with a DNR, documentation is everything. Now, in the past, that meant that we needed to have one of these documents along with the DNR to transport the patient and fully respect their wishes. However, in our rapidly changing pre-hospital and hospital interface, we're finding that DNRs are more often completely digitized. Therefore, you need to really get in with your agency to figure out what their specific rule set is on honoring DNRs. That being said, if at any time you're not sure that the DNR is valid, it's within your best interest to go ahead and complete cardiopulmonary resuscitation, do CPR. Because if you withhold on a patient that you had a kind of a sketchy remembrance, like, oh, I think they said they had a DNR and you didn't do CPR. Yeah, you just killed somebody, actually. And that's going to be a problem for you legally. It's going to be a problem for your service, and it's definitely going to be a problem for your continuance in this career path. Moving forward, other legal issues. Negligence. Boy, this is a big one. Now, negligence is basically you not doing your job. You had a job to do, you've been trained specifically on how to do it, and you either didn't do it or you did it incorrectly. And we mean you've done it incorrectly to an egregious standard. We're not talking about, oops, I put the blood pressure cuff up on their arm upside down. It's a mistake, but it doesn't really meet the measure of negligence. To prove negligence, we have to prove 4 very specific points. Here are the points in order. Number 1, duty to act. We have to show that you had a job to do and that you didn't do it. That leads us into point number 2, breach of duty. Now again, we've established that you were supposed to do your job. Then, by meeting number 2, we showed that you either did not do the job or did it so poorly that it was outside of what we would consider to be the standard of care. Point number 3, we need to prove proximate causation. This is a very big word that means one thing and one thing in particular. If you had not been there, the patient would likely have done a lot better. And then finally, number 4, we have to prove that there are damages. We have to show that particular damage occurred based on your inaction or based on the action that you actually went with. Again, to prove negligence, the lawyers, the law enforcement, the prosecution themselves have to prove that you had a duty to act, that you breached that duty, that there was proximate causation, and finally, that the actual damage occurred was because of your actions or inaction. We have a Latin term for this. It's res ipsa loquitur. Now, for those of you that aren't fluent in Latin, don't worry. It's been a dead language for a very long time. But res ipsa loquitur means, literally, the thing speaks for itself. This legal concept means that it can't be this big conspiracy theory. We can't have this massive, massive circle of, if this happened and this happened and this happened, the world is flat. It doesn't work like that. Negligence has to be clear-cut, and it needs to meet those 4 very specific items to be proven. Your duty to act is your obligation to take care of your patient. That obligation isn't always going to be clear. If you're off duty, your duty to act is much different than if you are on duty, and even if you're out of jurisdiction. So we're going to talk about that in just a minute, the duty to act, on duty and off duty. But I do want to focus on your on duty acts and your on duty actions. If you are working, if you are actively working as an EMT, you are driving around in a big old advertisement that says, help here. If you need help, we're here. But that doesn't mean that we're always available to answer the call. Now, to reemphasize, when we have our patient in our care, if we stop treatment or transport, if we don't follow through and transfer either to a medical personnel, a squad, another person at our level or higher, or transport them and transfer care to somebody that can take care of them at the legal level, like law enforcement, we would be hitting the mandated aspects of abandonment. So taking care of our patients, while important, we also need to understand the ramifications of what we're doing legally. When we talk about duty to act, we're typically, and we're really almost exclusively talking about what you do on duty. However, because you've been trained at a certain level, especially when it comes to CPR, general first aid, and the recognition of, of a medical emergency or some other type of traumatic injury and the resulting emergency, you may be asked to do your job outside of work. Thankfully, we have what are known as Good Samaritan laws. They differ from state to state and even from different municipalities, but the overarching theme is the same. Good Samaritan laws apply to folks that are off duty that are trying to do what's best for the patient. So, really, it's a good faith attempt at rendering aid. It rarely, if ever, applies to on-duty personnel. And as we talked about, these are life-threatening situations where, really time is of the essence and we need to make a command decision. In that instance, if we were on duty, we have certain provisions like performing an emergency move. Again, like we talked about last week, it's very rare that we perform emergency moves. So really what we're trying to say is you have the framework, you have the tools to do your job, but when you start operating in ways that are not consistent with that training, with that equipment, so on and so forth, you will start to run into cases of negligence. If you're off duty, you probably don't have those tools and that framework, so that's where Good Samaritan comes into play. Remember, it doesn't protect you from gross negligence or violations of the law. Gross negligence would be doing CPR on the abdomen, for instance, or deciding that you were going to transport a patient that was critically injured in your own vehicle when there were plenty of rescue personnel available to do that. So these would be some of the examples where Good Samaritan laws would not cover you. So don't just go out there being cowboy and gung-ho rescue Ricky. Yep, that's right. I showed up in my Acura and here we go. We're going to start doing some aid. We're going to start helping you out. Oh, my Lord, please don't do that. The best tool that you have in your tool bag when you're off duty is your cell phone. Letting the first responders that are on duty know where you are, what you see, providing a very accurate scene size up, and so on. They may even ask you to render some aid, but really, if you don't get the right people on the way, you're not doing your job. Now, we are moving away from the actual application of the legal system as it goes towards doing the job physically, and now we're moving into the legal and privacy related aspects of the job. Confidentiality really is anything that's going to refer to our patient's medical history, their current or previous complaints, and of course, anything that can be used to positively identify them or link them to the care that we're providing. We have a law known as HIPAA. HIPAA is the Health Insurance Portability and Accountability Act. Now, HIPAA in and of itself is a pretty robust law. It means that the laws themselves have a legal framework at the federal level that force us to, at the very least, meet that level at the state. So, HIPAA really has everything to do with maintaining privacy, not only in the care that we're rendering at the moment, but as we transfer care and move on down the line. So HIPAA is a big part of what we do. It doesn't mean that we need to whisper everything that we're doing. We do have what are considered allowable aspects of disclosure of information. An example of that would be if we're talking to the patient and someone overhears us refer to them by their first or last name. In a clinical setting, it would be something like a patient sign-in sheet or something of that nature. But really, at the end of the day, we need to be sure that we are protecting our patients' privacy because at the end of the day, it's no one else's business besides our own and the folks that are going to take care of them. Moving forward, we're going to talk about medical ID bracelets and medical ID devices, but I do want to let you know that if you do want to have a more in-depth dive into HIPAA, I'll be putting up a separate video on HIPAA awareness, HIPAA training, but also remember that your agency has a responsibility, a legal responsibility to not only train you in HIPAA, but to certify you in your awareness level. So at the very least here in California, that is a requirement of any EMT at a new job, but that's a pretty standard law in any aspect of healthcare across the United States. Moving forward, medical ID bracelets and medical ID devices. These devices will help you identify if a patient has some type of a pre-existing condition that may render them unable to tell us what's going on. These may come in the form of bracelets, necklaces, ID cards, even tattoos. They may even have a seatbelt cover in their vehicle that would indicate that they may not be as helpful as they could or should be because of a pre-existing condition, such as autism, Down syndrome, or some other type of issue. It may also indicate why our patient is unresponsive, unconscious, or otherwise if they have type 1, type 2 diabetes, a seizure disorder, or some other type of issue that would render them unable to answer our questions. These devices can be found all over the place. So look at your patient real quick. And of course, we're not even bringing up the cell phone aspect. If you haven't already, look at your phone, look at your device. It's either probably going to be an Apple or a Google device. I'm going to be real honest here. Find out how to unlock it to see medical identification information. A lot of people don't necessarily set them up, so don't be reliant upon it, but it is at least one route that you can follow down to see if there's some more information that might change what's going on with your assessment and our overall treatment. We also want to understand that this isn't just to insulate us from liability. It might change our course of action entirely. If you see that your patient is unresponsive and they have diabetes, the very first thing that you should be considering is, should I do a blood sugar check on this patient? As an EMT, we can't really fix the patient if they're unconscious, unresponsive, and their blood sugar is really that low, but it could change the kind of resources that we reach out for. If the patient is confused and awake and has an intact gag reflex, and we're in a locality where we can give oral glucose under those circumstances, and we have our glucometer and we've checked it and we're good to go, we can give them some oral glucose. Now, again, I want to let everybody know where you work specifically will be the determining factor on how these things will be incorporated into your day-to-day job. So please don't take what I'm saying as gospel. What I'm trying to really introduce you to are generalized concepts. And unless you work in the municipality that I work in, unless you work in California in general, some of these things may be drastically different. So as always, go back to the book, go back to your local EMS agency or your state and verify the information for yourself. Some other special situations that I just want to talk about real briefly. Organ donors. The fact that a person has an organ donor sticker or some kind of indication that they're an organ donor doesn't change the kind of care that we provide, but it may change where we take a patient if they have been deceased. Now, where I work, we don't typically transport anybody that is deceased that we're not actively trying to save, but it may change who they send out to retrieve that patient's body after they have been declared deceased. And it is certainly something that we want to mention if we do transport the patient to the hospital and things are not progressing in a positive manner. But remember, organ donors have no difference in the kind of care that we provide other than they have a viability to provide an organ to somebody that is not expired. So we want to make sure that that organ donor's wishes are recognized and honored. I only bring this up because an individual that has been banned from YouTube, sucks to suck, bro, but I'm not going to give them a platform, was running around saying that organ donor cards were being used by paramedics and EMTs to determine the kind of care that they were provided, and that somehow it was some giant cabal, a big conspiracy. There's a very good reason that person is no longer on this platform. I'm very, very happy that they're gone. But it is a bit of a shock, a bit of a punch to the old proverbial face of EMS to be accused of, basically denying care based on organ donor specificity and organ donor status. It's ridiculous, and it's not true. Next, safe haven laws. If you have not heard of safe haven laws, You may be in a municipality that does not honor these types of commitments, but in California, what we have is the ability of a new parent to surrender their child to a police station, fire station, or ambulance station, no questions asked. You really do need to be kind of aware of what your local municipality says on ages and different parts of the process. But our goal is to give the mother, and again, this is the mother, not the father. This is to give the mother, in most cases, the ability to safely and anonymously surrender the baby. But we also give them identification devices so that they can, in the future, be reunited with the child. Um, it's a great program that I have a lot of respect for, because it means that we don't have kids that are being abandoned directly after birth, especially out of hospital birth. But it is something that has very stringent rules and regulations, and it's your responsibility and your employer's responsibility to inform you on what those responsibilities are. I said responsibility a lot. Sorry about that. It's your employer's job and the county's job to tell you what you do need to perform to make sure that you're following through with all the safe haven. Crime scenes. As EMTs, we're going to be asked to respond to the scene of a crime on a regular basis. Our job may be to render aid to the victim. It may be also to render aid to the perpetrator. Our job is not to cast judgment, but it is to provide excellent care. After excellent care has been considered, we also want to try to do our best to preserve the crime scene. This means understanding what evidence can and cannot be, taking steps to preserve evidence, and trying to take a mental note and document what we did while on scene. Some examples of evidence would be the condition of the scene themselves, the patient themselves, clothing that they were wearing, especially if there was some type of penetrating wound, such as a stab or bullet hole, and making sure that while we are cutting their clothes, we are not damaging the entry or exit wound. Fingerprints, footprints, microscopic evidence, especially bodily fluids, or some other type of evidence that could be used to positively ID, or not just positively ID the perpetrator, but also exculpate or exclude individuals that were not involved in the crime, such as you, your partner, law enforcement, and other personnel that show up on scene. We also want to try to take into consideration the things that we touch, our impact on the scene, such as how we got in and left the scene, how we found the patient, and basically whatever we did to physically change the layout of the call. And then, of course, any work that we've done with the police. We have a separate but equal approach to law enforcement. We are absolutely working alongside law enforcement and EMS, but at the same time, they have a very different job to do. Their job is to enforce the law and to enforce safety and order. Our job is to ensure that our patients receive excellent care and to ensure that our patients are well taken care of before, during, and after our encounter with them. We also have special reporting requirements, and this may or may not be as a result of a crime. It may simply be because the patient is no longer able to take care of themselves, but for the most part, these are going to be crime and legal types of situations. Child, elderly, domestic abuse, violence, such as a gunshot wound or a stab wound, sexual assault, anytime that you need to restrain your patient because they're too violent or they are acting in a way that is going to put you or your partner at risk. And I wanted to highlight elder abuse. Now, this is a document that's used by financial institutions for suspected dependent or adult financial abuse. There are a lot of different types of abuse: physical, emotional, mental, sexual, and of course, with our adult patients, financial. One of the most common types of abuse that goes unreported are elderly patients that do not have control of their money. They literally have family members, sometimes even their own children, coming in and treating their checkbook as if it is some type of an open season for free money. They write themselves checks. It's really a sad thing. And, we get a lot of patients that say, I don't know what to do. Well, thankfully, in most places, we're considered mandated reporters. So here in California, EMTs are known as mandated reporters, meaning that if we suspect abuse of a child, of an elder, of anybody, we are required by law to bring up our suspicions to our immediate supervisor and go through the process of reporting. It depends on where you work, but for the most part, it's usually a two-part process. Part number one, you call in and give an oral report to a call taker or to a case manager, caseworker. Step number two, you document everything that's in that report. Depending on where you are, they may change the way that they do it in terms of order. You write it first and then talk it out. But basically, you have to have two forms of documentation, verbal and written. After that, you send everything in, and in a couple of weeks, you'll probably get some mail to your house that says, "Thank you for the report." And that'll be the extent of what you hear, unless you are subpoenaed or asked to show up into court to discuss your findings, your concerns, or your evidence as it relates to the case itself. We also have special reporting requirements for folks that are intoxicated, under the influence of drugs or alcohol with injuries, individuals that are mentally incompetent with injuries, and any time that we have a patient that overall has the look, smell, and feel of a crime victim, but is denying that a crime has occurred. Basically, if you think that something happened, if you have that gut feeling, go ahead and follow it through. Make sure that you're reporting it, because at the end of the day, you may be the only person that recognizes that something is happening. And worst case scenario, it's nothing, but at least we're getting additional eyes on to make sure that what we are seeing is or is not actually happening. That's it. Let's do the chapter review and get you on out of here. Number one, medical, legal, and ethical issues are a part of every single EMS call. Consent is something that needs to either be expressed or implied. If it is expressed, it needs to be informed. If it is implied, it is because the person is not able to accept or deny the medical treatment that you're about to provide. Negligence is failing to act properly when you have a duty to act. There are 4 parts to negligence. Those 4 parts are duty to act, breach of duty, proximal causation, and actual damages. Abandonment is any time that you leave your patient after you have initiated care and before you have transported that patient to a person with equal or higher training, whether that be at a medical level or, if the patient is stable and has no medical complaint, to law enforcement. Confidentiality is the obligation that we have to our patients to make sure that we do not reveal personal or identifying information with regards to their own health care and the services we are providing. We need to make sure that the individuals that receive this information are actually legally able to accept it, and that we do not reveal this information unless we are compelled under court order, or if your patient signs a release. As an EMT, you can be sued or held legally liable for any of these things that we've talked about today. Remember, anybody can sue anybody for anything. However, EMTs are rarely held liable when you have acted within your scope of practice and according to the standard of care, as well as presented with appropriate and detailed documentation. When we are at crime scenes, care of the patient takes precedence over everything else. Preservation of evidence is not ever paramount to taking care of our patient, but we do want to take the time and the effort to not disturb the scene unless we are providing patient care. So we want to make sure that we do not do anything that will negatively affect the impact of the police investigation, and hopefully, especially if we're dealing with the victim, get them justice as to the events that led us and the police to their home, to their location, wherever that may be. EMTs must use good judgment and decision-making skills anytime that we are dealing with consent or refusal. And then, of course, avoiding negligence falls under that good judgment. You need to have that critical thinking skill that we've talked about so many times and really try to hone that. Understand that EMT is rarely black and white. There's a lot of gray in what we do. Your responsibility as an EMT is to maintain your patient's protected health information. And a lot of that has to do with the legal and ethical obligations therein. But remember, if you are dealing with a patient, then it is your job to advocate for them. And that advocacy extends all the way into making sure that their information goes to the appropriate parties and isn't shared with other individuals that are not supposed to be accessing that. You may be compelled by a court of law to discuss their health information, but only under subpoena. So don't get confused and start giving information to the wrong people, especially when it comes down to your patients that may have a legal aspect associated with the case. So we can't just willy-nilly share all of our information with all parties on scene. And of course, if you're dealing with somebody that has some type of prominence, they're famous, they are a prominent individual, a politician of some sort, we definitely want to protect their information, because those folks are some of the first people that'll come after you for your slip up for saying too much. That pretty much takes us through Chapter 4, and that's Chapter 4 of the 13th edition of Emergency Care, published by Mr. Dan Limmer. It was a pleasure going through all of these legal and ethical issues with all of you. Please be on the lookout for additional supplementary PowerPoints and videos on all of this, and be sure to like and subscribe the video and leave a comment down below if you have any questions. I look forward to bringing you the next chapter, Chapter 5, in a very short few days, and I'm looking forward to going through the rest of the textbook with you all together. Have a great one. Be safe out there. Have a good one. Bye-bye.